Hi, I'm Dr. Jeff Demain. And as you know, we've been giving our first rounds of vaccines, both Pfizer and Moderna. And we've been seeing episodes of allergic reactions, some of which can be rather severe, such as anaphylaxis. So I'm going to provide a talk today that's going to talk about anaphylaxis with particular focus looking at our mRNA vaccines. So when we start talking about anaphylaxis, the core to that is a mast cell. Now, mast cells are throughout the body. They're predominantly tissue-bound cells. Mast cells can be activated by multiple triggers. What we usually think about is an allergic trigger, and that would be IgE, as you can see here. Well, IgE binds with an antigen, and then the IgE and antigen bind on the surface of the mast cell on a receptor called an FcR1, which is a high affinity IgE receptor. When that happens, the mast cell degranulates. You have the immediate release of granules such as histamine and proteases and heparin that cause a lot of sneezing, rhinorrhea, wheezing, congestion, flushing, skin symptoms. Then over very few minutes, then you have lipid mediators that are released, such as prostaglandins and leukotrienes. And then over the next several hours, you're going to have cytokines that are going to be produced. Now, these cytokines are going to turn on downstream immune activation and cell recruitment. And this is going to result in more severe, prolonged episodes. So let's talk about what's happening behind the scene. So as I mentioned, there are other mechanisms that mast cells can be triggered by other than just antibody. So thinking about an antigen-presenting cell, if you look up in the top left corner, you see an mRNA virus. Well, an mRNA virus or an mRNA as presented with a vaccine is taken up into an endosome in the antigen-presenting cell or dendritic cell. So that mRNA is recognized by that dendritic cell as being foreign and dangerous, or in this case, a pathogen. So two things happen. One, that dendritic cell is going to send this message to the nucleus. The nucleus is going to trigger the activation of interferon, which is antiviral, as well as interleukin-1. Interleukin-1 is also called a pyrogen. That's what triggers fever. But even though a dendritic cell doesn't have memory like we think of in our immune system, it can recognize danger and pathogenic associated patterns called PAMPs and DAMPs. So in this case, it's mRNA. It's going to be a PAMP, a pathogen-associated molecular peptide. When that occurs, this dendritic cell is going to activate a non-immune response. So the toll-like receptor 7 or TLR7 will directly activate the mast cell. So now you have an instantaneous mast cell degranulation. In addition to that, complement is activated, and you have complement split fragments such as complement C3A and C5A. And those will also activate mast cell in what is referred to as a complement activation-related pseudoallergy or CARPA. So again, this is going on behind the scenes before you even have the true immune activation. So again, we take a look at this cartoon, which really lays it out pretty nicely. You have the pathogen activation and the complement activation, which are innate immune responses. Then you also have the IgE bound with an antigen, and that is an antigen antibody response. That would be classically an allergic activation of the mast cell. So ultimately, you have multiple factors that are going on, multiple antibody and non-antibody triggers that are triggering and working this mast cell. Plus the mast cell itself is causing downstream activation. The bottom line is you have all these different factors, but it's anaphylaxis. So anaphylaxis is the end product. And that's what we need to recognize. Trying to go back and figure out what that is, what's causing it is important, but that's going to be something we do later. Initially, we want to recognize anaphylaxis. So let's talk about that. So anaphylaxis is a multi-system presentation. Most commonly, we're going to see skin symptoms like flushing, hives, or angioedema. Now, that can occur very early on These are what we refer to as cutaneous symptoms. Now, following that, we are going to see confusion. You can see neurologic symptoms, runny nose, swelling of the conjunctiva, again, angioedema, particularly facial and on the lips. You can have abdominal pain, nausea, vomiting. You can have pelvic cramping, such as because you get uterine cramping. Sometimes you can have loss of bladder and bowel. Then, of course, the worst events is when you have respiratory involvement, shortness of breath, wheezing, chest tightness, heaviness, hard to get a breath in, difficulty and painful swallowing. That has been a classic manifestation that I've seen throughout these allergic reactions to the vaccine. Additionally, you see cardiac events. That can be tachycardia, hypotension, although sometimes the heart rate can actually even be lower. Usually it's going to be tachycardic. So again, it's a multi-system process. And so review this and really get a feeling for all the different symptoms that can occur, because anxiety is one of the things we're trying to tease out as far as, well, maybe this is an anxiety reaction versus anaphylaxis. Understand that anaphylaxis produces very significant anxiety, oftentimes referred to as feeling of impending doom. All right, so how do we grade anaphylaxis? Well, we use what's called Mueller's grading system. It was first published in 1990. So a grade 1 is that generalized urticaria, that flushing, that malaise and anxious feeling, maybe some itching. But then you go into a phase 2. Now you've incorporated angioedema, or you can have one of the following two: chest or throat tightness, nausea, vomiting, diarrhea, abdominal pain, or dizziness. Then a grade 3 is dyspnea, shortness of breath, wheezing, stridor, dysphagia, again, painful difficulty swallowing, hoarseness, weakness, confusion. There's the feeling of impending doom or disaster. Then a stage 4 is hypotension. That would be collapse, loss of consciousness, and now you start seeing incontinence and cyanosis. So obviously this is very, very severe. Now, what are we using to assess vaccine reactions? Vaccine reactions are assessed with what's referred to as the Brighton collaboration anaphylaxis criteria. So to determine, was this truly anaphylaxis or not, in the panel number 1, if you have some skin manifestations, flushing, itching, hives, angioedema, and or either respiratory symptoms or blood pressure related symptoms, cardiovascular. Again, back to tachycardia, low blood pressure. In panel 2, we see you don't have to have skin manifestations. Like I said, 20%, 10%, somewhere in that range will not have skin manifestations. In fact, if there are no skin manifestations, that is a predictor of a more severe anaphylaxis. So don't let that fool you. You know, you may have a situation where there's no hives, so you're feeling comfortable. This could be a very severe event. But that is having 1 or 2 of the following, either respiratory symptoms, again, cardiovascular symptoms, or gastrointestinal symptoms. And then 3, this is when you're getting into hypotension, and cardiovascular collapse would also qualify. So any of these 3 panels would meet criteria for anaphylaxis. Now, when we talk about anaphylaxis, it doesn't come in only one way. You have anaphylaxis that can present in different ways. Most commonly, we see what we refer to as uniphasic anaphylaxis. Uniphasic means you have the antigen exposure, you have a quick peak in symptoms, the patient is treated with epinephrine, the symptoms peak and then defervesce. Typically, the epinephrine is going to work within about 5 to 8 minutes. And again, symptoms resolve maybe over the next 15 to 20 minutes. And then there's a 2-hour observation and the patient's done. So this is probably the most common we see. But the next is what we refer to as biphasic anaphylaxis. So biphasic anaphylaxis is you have the same antigen exposure. You have the rapid onset of symptoms. The patient is treated appropriately with epinephrine, and then you have a defervescence of symptoms. But then 1 to 8 hours, most commonly around 4 hours, you have a second event. And that second event can actually be even more serious than the first event. This occurs more commonly in children, up to about 15%, and in adults, about 2 or 3%. We see biphasic anaphylaxis more commonly when the epinephrine has been delayed. So again, delaying epinephrine can result in a more severe event, and a more potentially fatal event. So keep that in mind. There's recent data that says biphasic anaphylaxis may actually occur even as far out as 72 hours. I would say this is fairly uncommon. The next is protracted anaphylaxis. So this is someone that has their symptoms, their symptoms kind of build and they never get really sharply severe, but they accumulate. So they have symptoms that, maybe the patient's talked you out of epinephrine, or you've decided, no, we'll just treat that with antihistamine. Their symptoms really never quite get better, but they never quite get severe. Well, this occurs and then because of the absence of epinephrine or the delay of epinephrine. Well, now this person may experience anaphylactic symptoms for 72 hours. So this can go on for a long period of time where this whole thing could have been abated if epinephrine had been used. So that's protracted anaphylaxis. And I've actually seen 2 cases of that just in the last few weeks. All right, so when we look at anaphylaxis triggers, there are a multitude of them. Today, we're going to talk mainly about iatrogenic causes. So vaccines are going to be our focus. And vaccine anaphylaxis is actually very rare. It occurs in about 1.3 per million, and I'll show you how. So this was a study that was done looking at the vaccine adverse event reporting system from 1990 to 2016. So that's over a period of about 16 years. There were almost 5,000 reports sent into theirs. Those reports were reviewed, and 828 were identified as probably representing anaphylaxis, which made up about 0.17% of those 500,000. So when you take into account all the vaccines that were given during that period of time, what we came down to is 1.3 per 1 million cases that can develop anaphylaxis. Now, more recently, we'll talk about the Pfizer-BioNTech COVID-19 vaccine. From December 14th through the 23rd, they reviewed the VAERS reports, just as I just discussed. They reviewed almost 2 million first doses that were administered. Of those 1.9 million, 4,398 adverse reactions were reported. They looked at those and identified 175 that possibly could represent anaphylaxis. Each of those cases were very specifically reviewed, and it was determined by experts that 21 of them actually did meet the criteria for anaphylaxis, giving it an overall rate of 11.1 per million. So that's 10 times what we see in general with vaccines. Looking further at those data, we find that the median age is 40 years old. So it's really more on the younger to middle-aged population. 90% were female. And to date, every case that I've seen of anaphylaxis related to vaccine have been female. So that's unusual. I don't know why. No one really does, but I think it's very curious. And it's going to warrant further assessment. The median onset of symptoms was 13 minutes. The 71% reacted within 15 minutes, 86% within 30 minutes. That means there's 14% that are going to react sometime after they leave their observation period. When we look at the different underlying histories, 81% of the individuals had some type of allergy or allergic reaction. There was 8 that reported medication allergies, 4 with food allergies, 2 with insect stings, 2 with previous vaccines, and 1 with radio contrast media. So again, if this is an allergic individual, consider that when you're giving the vaccine. All right, so we look at the minutes, and I think this is important. So this is showing you the onset of symptoms within the group. So 71% within the 15 minutes, 86% within 30. But then you have that greater than 30 group, 14%. So those we should have a little more caution with. Now, why are we having anaphylaxis? Well, again, like I showed you earlier, there are several reasons that mast cells can be degranulated. But if it's an allergic reaction, the most likely culprit is the polyethylene glycol. Polyethylene glycol is found as one of the lipids in both the Pfizer and the Moderna vaccine. So when we look at polyethylene glycol, is that something that can cause anaphylaxis? Because polyethylene glycol is in numerous products. Well, there were 58 cases of anaphylaxis to polyethylene glycol that was used in a bowel preparation, something like Go Lightly. And that's, they look at polyethylene glycol 3350. The 3350 is the molecular weight of that polyethylene glycol. So you can detect this with testing, skin testing specifically. If you look at the graph on the right, you can kind of get a range of when these reactions occurred over this period of time between 2005 and 2017. So it's not unheard of, and it's actually thought that this probably occurs more frequently than we realize. And it's oftentimes now considered a hidden allergen. So to talk about polyethylene glycol a little further, it has been identified that this can occur on the first exposure. So we have medications that are what we refer to as pegulated. Now, so this is, again, an injectable medication. So first exposure can trigger an anaphylactic event. And it's also been identified that polyethylene glycol can cross-react with polysorbates. Polysorbates are commonly found in injectable medicines, particularly vaccines. There's not a good blood test to look for antibody reactions to polyethylene glycol, except one. It's a dual cytometric bead assay that was developed by Dr. Zoe at the FDA. And it's a very good assay looking at IgG, IgM, as well as IgE. And this is a clip from his paper, and it shows in blue, those are the patients, and those are the measurements they're seeing with antibody associated with polyethylene glycol. And then in the orange, really showing no reaction, are those that are controls that are not allergic. On the right, you can look at the structure of polyethylene glycol, and you can see in polysorbates, you really have a repeated pattern of that structure. So you can easily see why there would be cross-reactivity. So when we're looking at polyethylene glycol anaphylaxis, I mentioned earlier that you can measure sensitivity. And this is done predominantly by skin testing. There's actually 4 papers that have been published looking at skin testing for polyethylene glycol. And this is going to be a 3-step process looking at 5 different molecular weights. So we're working on developing or putting together this test, but it's a little difficult to identify and find and purchase each of those molecular weight polyethylene glycols. But once we do, we're going to be testing patients that have had anaphylaxis or suspected anaphylaxis. There's also reports of doing vaccine tests as well, and we may or may not be able to do that. So I already mentioned that it's found in multiple products, including things like Go Lightly and Miralax. But it's important to understand you're going to have a much greater risk of having a reaction to something that's injected or parenteral compared to something that you take orally. So I believe that's an important message to walk away with. So when we think about these symptoms, this anaphylaxis-like picture, what could be the differential diagnosis? Well, in a case like this, people are reacting following an injection. I think we pretty well have our suspect. But there's multiple aspects of this, and this is really kind of my job to figure out exactly what is the underlying mechanism. But in the meantime, for us, when someone's having anaphylaxis, our job is to treat that patient. So how do we distinguish at the scene where you've given the vaccine, the patient is having symptoms? How can we make the distinction? Is this anaphylaxis or an allergic reaction? Is this a vasovagal reaction, or is it a vaccine side effect? So let's take a closer look. This is from the CDC slides. So an immediate allergic reaction that usually occurs within that 15 to 30 minute period. They can have that feeling of anxiety, feeling of urgency, maybe even feeling of doom. They're scared. They can have skin symptoms like flushing or hives or angioedema, and that can occur within around 90%, I would say 80 to 90%. And remember, if they don't have skin symptoms, that could predict a more severe event. They can also have neurologic symptoms like confusion. It can be disoriented, dizziness, lightheadedness, even loss of consciousness, shortness of breath, wheezing, bronchospasm, stridor, chest tightness, heaviness, hypotension, tachycardia, nausea, vomiting, abdominal cramping, uterine cramping. So these are patients that would really quite meet the criteria for an allergic reaction. Obviously, they don't have to have all of those symptoms. If they go one step beyond the skin, we usually refer to that as anaphylaxis. Should they receive a second dose? Absolutely not. The next group, what about a vagal reaction? These often occur very quickly as well, usually within 15 minutes. The patients feel warm, sometimes cool, they get pale, they get sweaty, they're clammy. They also can have dizziness and lightheadedness. They can have weakness. Oftentimes, from a respiratory standpoint, they might be breathing fast. They definitely feel anxiety. They can have low blood pressure and bradycardia, which is probably more classic with vagal events, but that's not necessary. Nausea is also common. So oftentimes patients with a vagal event, you can lay them down, prop up their feet, give them some reassurance, and usually the symptoms will resolve on their own. Should they receive a second shot? The answer is yes. Now, what about local reactions or side effects? These can occur anywhere from a day to 3 days out, and it can trigger fevers, chills, fatigue. Obviously, you can have pain, redness, and swelling at the site. Sometimes patients are describing headaches. There have been some reports of gastrointestinal symptoms and muscle aches and joint aches. So these can occur. They're local side effects or systemic side effects. Should they get another vaccine? The answer is yes. So the likelihood of them having something more severe with a subsequent vaccine, it would be very low. How do we manage anaphylaxis? Well, I should put this in even bigger letters, but epinephrine is a treatment of anaphylaxis. It's the primary and most important treatment. In adults, you want to give a maximum of 0.5 milligrams. In children, you're going to think more about weight. 0.01 milligrams per kilogram of 1 to 1,000, and with a max of 0.3 milligrams. This should be intramuscular, and it's going to be in the upper outer thigh. That's really a very critical point. Giving it in the arm is not appropriate, even though it may be inconvenient in an open setting. It should be administered in the thigh. Once the epinephrine is given, the patient is now in a recumbent position. Their feet are propped up. They're getting their vital signs. They've had their epinephrine. Now it's time to call 911. Or you can activate whatever emergency system you have. Obviously, there are many places in Alaska. There is not a 911, but there's always going to be some type of emergency activation. So the patient should continue to be monitored while they're in that semi-recumbent position. So epinephrine, again, is key. This is right out of the CDC website. Again, it's telling you the very same thing, that epinephrine is first-line therapy. It can be repeated every 5 to 15 minutes as needed, and there are no contraindications to epinephrine during a life-threatening anaphylaxis. When you look at antihistamines like H1 and H2 blockers and bronchodilators, they may have a role, but they do not have a role in the primary treatment of anaphylaxis. They have a role in treating some downstream symptoms. So treating someone with Benadryl or antihistamines like Zyrtec for anything beyond skin reactions would be inappropriate. Now, sometimes with someone's just having flushing but no systemic symptoms, antihistamines may be helpful. But again, anything beyond the skin, that is an inappropriate therapy. And they only should be administered after epinephrine. So again, it's the most effective. There's no contraindications. Failure to administer it or delay in administration it has been linked with fatalities. So that is a really key takeaway point. Now, why do we give it IM instead of sub-Q? Well, intramuscular, the onset of action is 8 minutes plus or minus 2. If you give it subcutaneous, the onset of action is 34, plus or minus 14. However, it can be up to 120 minutes. So this was work done by Estelle Simons, 2004, and it still holds. So IM versus sub-Q. Then we look at this graph, and we're seeing the purple line represents sub-Q, the red line represents intramuscular, and you can see a dramatic increase in the plasma or systemic absorption of anaphylaxis if given intramuscular. Now, this is an interesting slide. I don't even know the source. This is one that I had in an old slide deck, but they looked at intramuscular in the thigh, intramuscular in the arm, and sub-Q in the arm. And what you can see is IM in the arm or sub-Q in the arm really doesn't even have an advantage. You can see that green and blue line that really shows very minimal uptake. Whereas given in the thigh, whether it's done by auto-injector or done by a drawn-up syringe, you have a very nice, very brisk uptake of the epinephrine in the plasma. So again, remember, give it in the thigh intramuscularly, upper outer quadrant. Now, when someone is having anaphylaxis, what should we do? Well, once they're stable, it's important for us to do some lab tests too. We want to be able to determine, is this anaphylaxis real? What else might be going on? So when you first have anaphylactic event, there is an immediate uptake. Let me see if I can show you on here. So you have an immediate rise in what's referred to as plasma or histamine. So histamine rises very quickly, and that makes sense. That's coming out of the mast cell, but it also goes down very quickly. So measuring serum histamine is really not very valuable, because by the time we get to it, once we've stabilized our patient, the histamine level is already down. But mast cell tryptase rises as well. It peaks at about an hour, and we want to measure it somewhere between 30 minutes and 3 hours. So there is your line, 30 minutes to 3 hours. After about 3 hours, we start seeing the tryptase going down quite rapidly. So kind of keep that in mind. You'd like to draw this mast cell tryptase. The CDC recommends drawing tryptase. They also recommend measuring what's called membrane attack complex, which is an SC5b-9. This can be ordered through Quest. It's done at National Jewish. It's not readily available, certainly, and maybe in some of the more remote areas, it would be very difficult to get that test. I would recommend considering what's referred to as a CH50. So a CH50 is kind of measuring the entire complement complex. All right, so what about the supporting lab data? Why is it beneficial? Well, serum tryptase, again, is released early, and it usually is measurable within 15 minutes, but 30 minutes to 3 hours is kind of optimal. Not all anaphylactic events are going to have elevated tryptase. In fact, in food-induced anaphylaxis, about 35%. Will not have measurable tryptase. But other things can have high tryptase as well. Mast cell disease like mast cell activation syndrome, mastocytosis, monoclonal mast cell disorder, and postmortem. So if you draw a tryptase level on someone that is passed, their tryptase is going to be high. But it is important for us to establish this. And then we draw tryptase later down the road, once they've stabilized several days or weeks out, to determine what is their normal level, and then we do a mathematical calculation to determine whether or not there was significant tryptase release. Now, we can also do urinary metabolites. This is something you might consider. If tryptase was not ordered, you can order an N-methylhistamine, prostaglandin D2, and leukotriene E4. That in a perfect world, do that with a 24-hour urine sample. Otherwise, you can do it with a spot urine. So consider that. It's not required, but that may be interesting data. But again, remember, if their tryptase level doesn't go up, that does not rule out anaphylaxis. So when you're giving vaccine at your site, the CDC says that you must have epinephrine in prefilled syringes or auto-injector, antihistamines on hand, such as diphenhydramine or Benadryl, blood pressure cuff, stethoscope, and something to time pulse. Usually a pulse ox works pretty nice for that. In a perfect world, when it's feasible, you also want to have a pulse oximeter, oxygen on hand, a bronchodilator, an H2 blocker such as famotidine, intravenous fluids, an intubation kit, and a pocket mask. So the key message from the CDC, and hopefully from me, is you want to be able to recognize anaphylaxis early and treat it. Prompt treatment with epinephrine, and then activate whatever emergency service you have, which may be 911. It may be notifying someone, a health aide that's in the clinic. Now, this was recently updated. This is triaging patients for preventing the mRNA vaccination reaction. So precautions to vaccination, let's talk about that first. That would be history of any immediate reaction to vaccines or injectable therapies. Should be at least discussed, possibly deferred, pending a evaluation by an allergist immunologist. If it's decided to go ahead, then there should be certainly a 30-minute observation period. So again, risk assessment. And so vaccines or any injectable therapies that were associated with an immediate reaction. Now, what about contraindications to vaccine? There's significant change there from what was previously published. So history of the following are contraindications: severe allergic reaction or anaphylaxis after previous dose of mRNA vaccine or any of its components. Now, this is what's changed. Immediate allergic reaction of any severity to a previous dose of an mRNA COVID-19 or its components. So any severity. Immediate allergic reaction of any severity to polysorbate. Again, they cross-react. That would be usually found in another injectable product, such as a vaccine. So it's also important that once this is over, we've taken a breath, we've taken our own pulse, the patient's doing well, you have to fill out a VAERS report. It's easy to do. You can go online. It takes really just a few minutes to do it, but this is critical information. So it's our responsibility as physicians to fill this out. Certainly you can get the help of one of your assistants, but you want to get this done because this is how we learn more about these vaccines. So finally, I want to talk about vSafe. As you know, vSafe will follow the patient after they've received their vaccine over the next days and weeks. It's a very easy system to use. You've probably done it yourself. This will provide very important information to the CDC in helping to guide us and helping to identify if there are any problems that require further investigation. So I hope this has been a helpful program for you, and you have a better opportunity now to recognize anaphylaxis, how to manage anaphylaxis, and then what to do after the anaphylaxis has occurred in contacting VAERS. So good luck and stay safe.